Okay, so thank you once again, and I'm going to be talking about stepwise imaging. And I think the reason why this is important is because we have so many machines with us, and we're talking about multimodal imaging in almost all conditions. But I'd like to begin with this disclaimer that you don't need to do everything in every patient. So let's talk about infectious retinitis mainly. I'll briefly touch upon a few others. We all know clinically it's very easy to diagnose acute retinal necrosis and CMV retinitis. They have a set pattern, the phenotype is quite characteristic, but sometimes when you have a necrotizing retinitis, which is a blinding disease, you have a patient in the clinic and you could get confused between a viral retinitis and let's say a toxoplasma lesion or even a lymphoma like it was pointed out. So what do you do? When you are in the clinic, you can't expect a lab test to come to you immediately. So you need some help. And this is when you probably rely on some imaging modalities. And what I like to do in my patients is when you have a presumed viral lesion, which is fairly peripheral, if the lesion is not amenable to a good OCT, like Adrian was talking about in the context of tumors, you just do a fluorescein angiography and look at the pattern of vascular involvement. If you have a predominant arteriolitis with retinal hemorrhages, it is quite characteristic of a viral retinitis. On the other hand, if you have an OCT, I think you are at an advantage where you could image at the peripheral retina and look at directly the full thickness retinitis along with a pattern which we call as cavernous retinitis, where you have empty spaces within the inner retinal tissue and you have a full thickness pattern of retinitis. When we talk about CMV retinitis, CMV is a little difficult disease to manage, although it's not so difficult to diagnose, especially in the context of HIV, but you have non-HIV related CMV retinitis. And I've had a couple of patients who have had immunodeficiency with conditions such as Good syndrome. They could have CMV retinitis. So in these patients, you look at two patterns of retinitis. One is the full thickness pattern, and the other is the cavernous pattern, which I just mentioned, where there is severe destruction of the outer retinal layer and optically empty spaces, cystoid-like spaces connecting the necrotic retina. So this is an image here of a patient with CMV retinitis, and you can see the vitritis is so exuberant. And I'd like to acknowledge my friend Alessandro Invernizzi, who's shared these images with me. And you can see the vitritis is almost like a nebulous vitritis, and you could have what is called as these volcanic eruptions. And these volcanic eruptions in the in the retina could actually indicate either a CMV or even a toxo, but this is quite characteristic in these two conditions. You would also have a clear premacular bursa. So it's usually there is a clear area between the vitreous and the involved retina. So in patients with the CMV retinitis, you could have a full thickness pattern like the ones shown above. These full thickness patterns are the one where you have a swollen RPE, and if you magnify the OCT, you realize that you have these vertical strips. They're running vertically from the RPE to the inner retina. And it is presumed that these vertical strips are the path of the viral activity. Probably the active virus is using these pathways to enter into the inner retina. Whereas if you have a cavernous pattern of involvement, you have these large empty spaces. These large empty spaces with bridging retinal tissue. And I think these are the eyes which could predispose to rhegmatogenous retinal detachments. So I think identification of the phenotype on OCT becomes important. This is another example here where you have a significant amount of bridging retinal tissue. The retina is almost detached over here. It's just a fine line there which is holding on. And this is a characteristic pattern of viral retinitis. So if you have a good peripheral OCT, you can look at these images and diagnose. Some of the features of necrotizing retinitis, such as thickening, disorganization, hyperreflectivity, this is something that you will see in all patients, whether it's a viral or it's a toxoplasma. In fact, you will also probably see them in a lymphoma. And Shields has described a series where she has patients of lymphoma which mimicked retinal necrosis. So these are some common features that you're going to find. But what's different in toxoplasma, and something which is very obvious in a toxoplasma lesion, is the disruption of the choroidal architecture. Now you have two case examples here. Both are CMV retinitis. one is HIV, and one is a renal transplantation. And you realize that the RPE, or the underlying choroid, is almost normal. You don't have focal swelling of the choroid. This is another patient here. These are two patients. One is a patient of CMV retinitis with HIV, and the other is a patient of herpetic retinitis. You find these vertical strips, and you might have an intraretinal edema, but none of these features are really pathognomic. But we found that there are some features which can help you. So intraretinal edema can actually help you. This is more common in viral retinitis. I haven't seen this in toxoplasma. On the other hand, in toxoplasma, the choroidal hyporeflectivity, I think, is the single most important feature that you can see on the OCT. If you have a choroidal hyporeflectivity and enlargement, you could be reasonably sure that this is a toxoplasma. Moving on, so this is a patient here who is a 33-year-old Emirati patient, came to me with decreased vision in the right eye, and he had a condition where he had enlarged adrenals bilaterally. Since childhood, he was diagnosed with congenital adrenal hyperplasia on corticosteroids. And he was on fludrocortisone. And I think if your patient is on fludrocortisone, this is a very important risk factor for developing an infectious retinitis. So this patient had involvement of the right eye, and also the left eye had cells. And you can see wide field imaging captures beautifully the area of necrosis. And you could use these images, serial images, to look at a 360-degree involvement of the retina. So this patient with 360-degree necrotic white lesions, unless otherwise proven, this is an acute retinal necrosis. Very rarely you could have an atypical toxoplasma and lymphoma, but do keep them in mind. I mean, you shouldn't rule out just based on your impression. So if you look at the near infrared, I think it gives you good information. You could capture retinal vasculitis on infrared imaging. I'm not going to go into details of that, but there are clinical signs that even the near infrared is sometimes enough. And you can have these stalagmite-like deposits. These stalagmite-like deposits are seen both in viral and toxo. They're not pathognomic for any. Again, you have these full thickness retinal necrosis here, and you can see these bridging tissues. And this patient, if the patient comes to me again, I would tell the patient you're very highly likely to develop a retinal detachment. And this is what happened. This patient actually went on to develop a rhegmatogenous detachment. So absence of choroidal involvement here on the OCT. You look at the OCT, there is no choroidal involvement. And this is why this is against toxo. And you'll have in lymphoma big elevation of the retinal tissue, and that's called rounded roof configuration, which is clear in lymphoma. So this patient underwent treatment with the antivirals. Now, the patient subsequently improved. So I'm just going to spend 1 minute, a couple of minutes actually, 1 minute on this slide. This is a patient where you have, this is a situation where you have TB. And in TB choroiditis, I think following a stepwise approach is quite useful. We had some discussion in the morning about autofluorescence and fluorescein angiography. In my personal opinion, I think autofluorescence is the single most important test, especially in the initial assessment of the patient. It very effectively gives you the activity of the lesion. The OCT adds on, it helps you to find out the nodularity, but the autofluorescence actually gives you the entire extent of the disease and tells you which is the active area. I always obtain a fluorescein and ICG at baseline in my patients of serpiginous choroiditis. And I do repeat the fluorescein and ICG when I suspect either paradoxical worsening or non-response. But in my mind, I think every visit the patient should have an autofluorescence on the same device. Don't try to change from Optos to Spectralis. Finally, OCTA is good to look at. You could sometimes pick up choroidal neovascularization, but I don't use it very often. I'm going to skip this. This was covered by Dr. Mahesh sir. And finally, this is the white dot syndrome. So when you're suspecting white dot syndrome, you could classify the patients based on the fundus appearance. When you have foveal granularity, it is going to lead you to mudes. And when you have the presence of foveal granularity, look at the OCT and the autofluorescence. And you would use your more confirmatory tests such as ICG to be able to confirm where you have hypo to hypo lesions in mudes. remember your OCT angio will be completely normal. When you have multiple punched in rounded lesions, you are going to either have PIC or MFC. I think they belong to the same spectrum. You will have hyperreflective lesions breaking through the RPE. Yes, just 30 seconds. So, when you have large, deep, creamy lesions, along with patchy involvement, a plaque-like involvement of the posterior pole, think of AMPE, and I think AMPE has a characteristic appearance on both fluorescein angiography, ICG, and OCTA. You will have choriocapillaries flow void in all of them. So with this, thank you so much, and I'm happy to take any questions.
So, Aniruddha, surprised to see that much inflammation in CMV retinitis, because usually with a viral retinitis, you associate much more inflammation with herpetic disease and much less with CMV, because the CMV patients are typically significantly immunosuppressed. So that surprised me a little bit to see that much in that patient.
I think the spectrum of CMV is changing since we have the heart, and since we have lots of patients who are being managed with immunosuppressives for other reasons, such as renal transplants, organ transplants, cancers. I think these patients have still a robust immune system. So I think the spectrum of CMV is changing over the years.
The cavitary appearance that you showed on the CMV, that split is that in the outer nuclear layer? Is that this is different to a basilar layer detachment?
So it appears to be in the outer nuclear layer. I'm not sure why is it in the outer nuclear layer, why it happens, but I think it's a precursor for detachments. I don't know why it happens there.
So if I can add to that as to why it happens in the outer nucleus. So this is also a classical sort of an appearance which you'll see in PON, progressive outer retinal necrosis. And what happens is that the virus causes sudden ischemia, occlusive vasculitis over there, and you see this entire necrosis and loss of tissue over there. That's why you see that cavitatory sort of a lesions over there in CMV, and that is also what you will see in progressive outer retinal necrosis also, that sort of appearance. For just one more thing, Professor Stewart, when we were discussing about how you see that sort of intense inflammation, now the thing is that that inflammation, if you look at it otherwise, even in CMV retinitis, is just localized to that specific area over the lesion itself. You don't see a generalized vitritis like what you would otherwise expect in any other inflammation. And because CMV retinitis patients otherwise are immunosuppressed, the vitritis tends to be much lower, like what you said. But if you do an OCT just absolutely over that area of retinitis lesion, just above that, in that area, you will find those inflammatory cells.
Thank you. So I think with this, we'll end the session with the message that no matter how good imaging you have, always trust your clinical judgment, and the labs, ultimately, they are going to give you the answer. Thank you so much, and I'll hand over to Jay for the next session.
Thank you, sir.